Good morning. This is Dr. Sherilyn Santiago Salimo, and today I'm going to discuss about the oncologic emergencies. Oncologic emergencies are classified into three groups. First is secondary to pressure or obstruction caused by a space or occupying lesion, metabolic or hormonal problems, and treatment-related complications. So we will discuss one from each group. So for the first one, superior vena cava syndrome. So the presence of a tumor may cause superior vena cava obstruction, and this cause severe reduction, and this will cause severe reduction in venous return from the head, neck, and upper extremities. There are two possible causes of superior vena cava syndrome. It may be secondary to a malignant etiology, or it may be secondary to a benign etiology. But majority of the cases are secondary to malignancy. Lung cancer in particular, specifically the small cell and squamous cell histology, accounts for 85% of all cases of malignant origin. And in young adults, malignant lymphoma is the leading cause of superior vena cava syndrome. So other solid tumors that usually causes superior vena cava syndrome includes metastatic tumors from testicular cancer and breast cancer. For the benign etiology, it usually comprises 40% of the cases, possibly secondary to an intravascular device such as permanent central venous access catheters, some benign tumors, and aortic aneurysm. So what are the clinical manifestations of superior vena cava syndrome? So in terms of presentation, we can usually see neck and facial swelling, dyspnea, cough. Usually bending forward aggravates the symptoms. Other additional presentation can be hoarseness, tongue swelling, headaches, nasal congestion, epistaxis, dysphagia, pain, hemoptysis, dizziness, syncope, and lethargy. In terms of the physical examination findings, we can usually see dilated neck veins, collateral veins covering the anterior chest wall, cyanosis, edema of the face, arms, and chest, and in severe cases, we can see proptosis, glossal and laryngeal edema, and obtundation. So this is more or less a picture of the usual presentations of superior vena cava syndrome patients. So again, letter A, we can see edema of the chest, B, dilated neck veins, C, cyanosis, D, lymphedema, E, collateral veins covering the anterior chest wall. Other findings again would be facial and neck swelling, and at the same time, a flushed skin as well. Always remember that the diagnosis of superior vena cava syndrome is still clinical, but let's also discuss two imaging studies that may more or less give us a clue or an idea if the patient is having superior vena cava syndrome. So on the left side, this is a chest radiograph of a 59-year-old man with recurrent superior vena cava syndrome. He has non-small cell lung cancer, showing right paratracheal mass with right pleural effusion, as you can see here. This is the mass, and this is the pleural effusion. Computed tomography of the same patient demonstrates obstruction of the vena cava, the lung cancer, which is causing the obstruction, and the collaterals that are forming. I have a better picture in the next slides. So again, I just used another chest X-ray film to demonstrate more or less a possible presentation of superior vena cava syndrome. So the most significant chest radiographic finding is usually widening of the superior mediastinum, most commonly on the right side, as more or less shown by the red arrow. Pleural effusion also occurs in 25% of the patients, as more or less shown by the yellow arrow. So majority of these infusions are exudative and occasionally chylous in character. However, always remember that a normal chest radiograph is still compatible with the diagnosis if other characteristic findings are present. Excuse me. For the chest CT scan again, actually this is the same scan as from the previous slide. So CT scan provides the most reliable view of the mediastinal anatomy. So the diagnosis of superior vena cava syndrome requires diminished or absent opacification of central venous structures with prominent collateral venous circulation. So again, same with the previous picture. This is the obstruction of the superior vena cava with thrombosis by the lung cancer, and more or less shown here are the collaterals that were formed. Magnetic resonance imaging, or MRI, is increasingly being used to diagnose superior vena cava obstruction with 100% sensitivity and specificity. However, this SVCS patients, which is, of course, take note, that would be the most common presentation, may have difficulty remaining supine for the entire imaging process. And as we all know, MRI will take a longer time as compared with your CT scan and X-ray. Okay. So for the diagnosis, for patients with known cancer, appropriate treatment after CT scan of the thorax should be done. And for those without history of malignancy, detailed evaluation should also be done to rule out benign causes and to determine a specific diagnosis to direct the appropriate therapy. So treatment for superior vena cava syndrome is divided into two. On the left side would be the supportive treatment, and on the right side would be the definitive treatment. So under the supportive treatment, these are more or less support to provide symptomatic relief. So we can give diuretics such as furosemide. We usually order head elevation of at least 30 degrees and oxygen support. In some cases, glucocorticosteroids may be of benefit specifically for patients diagnosed with lymphoma. Let's go with the definitive management. So the definitive management will depend on the type of malignancy that caused the superior vena cava syndrome. Radiation therapy is usually the primary treatment for SVCS caused by non-small cell lung cancer and other solid tumors, while chemotherapy is the primary treatment for chemo-responsive tumors such as small cell lung carcinoma, lymphomas, and germ cell tumors. And more or less, third option would be stenting, but for the definitive treatment, it would either be radiation therapy or chemotherapy. Okay, for the second oncologic emergency, we have hypercalcemia of malignancy. This occurs in 20% of patients with cancer. So there are various ectopic hormones that may cause this abnormality. But the most common would be the parathyroid hormone-related protein, which is usually secreted or produced by squamous cell type of carcinoma from head and neck, lung, skin, at the same time of the breast, genitourinary or gastrointestinal malignancies. For lymphomas, the most common ectopic hormone would be your 1,2,5-dihydroxyvitamin D. For lung and ovarian, we can also more or less see parathyroid hormone, but rare. Renal and lung prostaglandin E, but also rare. So the most common would be your PTHRP, followed by 1,2,5-dihydroxyvitamin D for your lymphoma. So parathyroid hormone-related protein. So this is a protein member of the parathyroid hormone family secreted by mesenchymal stem cells. So it is occasionally secreted by cancer cells like breast cancer, certain types of lung cancer, specifically the squamous type. However, it also has normal functions in the bone, tooth, vascular, and other tissues. So PTHRP is related in function to the normal parathyroid hormone. So when the tumor secretes PTHRP, this can lead to hypercalcemia. As this is sometimes the first sign of malignancy, hypercalcemia caused by PTHRP is considered a paraneoplastic phenomenon, PTHR1, which is responsible for most cases of humoral hypercalcemia of malignancy. Lastly, PTHRP shares the same N-terminal end as the parathyroid hormone. Therefore, it can bind to the same receptor, the type 1 PTH receptor. So PTHRP can stimulate most of the actions of PTH, including increases in bone resorption and distal tubular calcium reabsorption, and inhibition of proximal tubular phosphate transport. And PTHRP lacks the normal feedback inhibition of PTH. What are the usual clinical manifestations? Okay, in some patients, you can just, sometimes we discover hypercalcemia by doing a routine blood exam. But for markedly increased calcium level, as shown here, more than 3.5 mmol per liter or 14 milligram per deciliter, usually these patients have symptoms already. Signs of fatigue, mental status changes, dehydration, and symptoms of nephrolithiasis. If we are going to apply this um, with a case, it what usually happens or what we commonly see, for example, the patient is a diagnosed case of advanced squamous lung carcinoma. For example, the patient have uncontrolled cancer, inadequate treatment, and then at the same time, for example, the patient had an acute gastroenteritis. The patient ended up being dehydrated. Sometimes you will observe more or less mental status changes, fatigue, and because of a triggering factor, which is an infection, which also led to dehydration, upon checking the laboratory results, you may commonly encounter elevated calcium. So infection sometimes can trigger hypercalcemia of malignancy, more or less poor nutrition, and dehydration. And of course, more importantly, uncontrolled cancer, especially those with who chose not to receive any treatment. Okay, so for the diagnosis of hypercalcemia of malignancy, of course, known malignancy with recent onset of hypercalcemia, very high calcium levels as mentioned from the previous slides, and upon further examinations, we can see hypercalciuria, hypophosphatemia, metabolic alkalosis by arterial blood gas, and other more or less diagnostics that can help would be suppressed PTH, elevated parathyroid hormone-related protein, and sometimes elevated 1,2,5 dihydroxyvitamin D in lymphoma cases. How do we treat hypercalcemia of malignancy? Definitely, hydration is very important. So we hydrate the patient with plain NSS, usually 200 to 500 ml per hour to dilute calcium and promote calciuresis. Forced diuresis with furosemide, 20 to 80 milligram IV to promote calcium excretion. However, there is little value in forced diuresis with the exception of life-threatening hypercalcemia. Oral phosphorus to attain serum phosphorus of more than 1 mmol per liter. If the patient will not respond to hydration, the second option would be to give your bisphosphonates. Example of bisphosphonates would be your pamidronate, zoledronate, and etidronate. Etidronate. So this can reduce serum calcium in 1 to 2 days and suppress calcium release for several weeks. In our country, the most commonly used would be your zoledronic acid. Um, Usually, the maximum dose is 4 milligram IV. To run for 15 minutes. So what is the mechanism of action of your bisphosphonates? So bisphosphonates inhibit bone resorption. So bone resorption, more or less, this is the process by which osteoclasts break down the tissue in bones and release the minerals, resulting in transfer of calcium from bone tissue to the blood. So your bisphosphonates inhibits bone resorption, so it reduces calcium efflux from bone into the circulation, leading to the development of hypocalcemia. Okay, if the patient is not responsive or still not responsive to your bisphosphonates, another medication that you can give would be your calcitonin, 2 to 8 units per kilogram subcutaneous every 6 to 12 hours, especially if rapid correction is needed. Again, for supportive treatment, you can also give glucocorticoids in cases of lymphomas, multiple myelomas, and leukemias. But if the patient is not responsive to all of the mentioned medication or intervention, the last resort would be dialysis. If saline rehydration and bisphosphonates are not possible or too slow in onset. So next would be the third oncologic emergency is your tumor lysis syndrome. So this is caused by rapidly proliferating neoplastic cells. So please remember the following. TLS is characterized by 3 hyper and 1 hypo. So hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. In TLS, acidosis may occur and acute renal failure may develop. So TLS is most often associated with the treatment of Burkitt's lymphoma, acute lymphoblastic leukemia, and other rapidly proliferating tumors. So the consequence of treatment usually is within 1 to 5 days after chemotherapy. Rarely, spontaneous necrosis of malignancies causes TLS. Why this type of malignancy? So remember, these are rapidly proliferating tumor, more than as compared to your solid tumors. So it means that they are very responsive to chemotherapy. So if the tumor is very responsive to chemotherapy, more or less the degradation of the tumor may be too much for the kidney to handle at the same time. That's the purpose of your tumor lysis, TLS prophylaxis, in order to support your kidneys and to prevent acute renal failure. So let's discuss the more or less features of tumor lysis syndrome. So number 1 would be your hyperuricemia. So effective treatment, again, as I have mentioned, kills malignant cells and leads to increased serum uric acid levels from the turnover of nucleic acids. So owing to the acidic local environment, uric acid can precipitate in the tubules, medulla, and collecting ducts of the kidney, leading to renal failure. So lactic acidosis and dehydration may contribute to the precipitation of uric acid in the renal tubules. So the finding of uric acid crystals in the urine is strong evidence for uric acid nephropathy as well. So the ratio of uric acid to urinary creatinine is more than 1 in patients with acute hyperuricemic nephropathy and less than 1 in patients with renal failure due to other causes. Okay, so next is hyperphosphatemia. So hyperphosphatemia can cause more or less or can be caused by the release of intracellular phosphate pulse by tumor lysis. So it produces a reciprocal depression in serum calcium. That's why we have hypocalcemia. So hypocalcemia can cause severe neuromuscular irritability and tetany in very low levels as well. And deposition of calcium phosphate in the kidney and hyperphosphatemia may cause renal failure. For hyperkalemia, so remember that potassium is the principal intracellular cation, and massive destruction of malignant cells may lead to hyperkalemia. Hyperkalemia in patients with renal failure may rapidly become life-threatening by causing ventricular arrhythmias and sudden death. Okay. So, TLS or tumor lysis syndrome is related to tumor burden and renal function. Tumor burden, how bulky the disease is. So we can assess that by checking the LDH level of the patient. So usually if there is it is a high tumor burden if the LDH is more than 1,500 U per liter. And if the presence of elevated uric acid or hyperuricemia. So if the patient presents with one or both of the following, then the patient is at high risk of developing tumor lysis syndrome. So prior to starting the treatment, again, baseline levels of kidney function should be obtained. Check out other problems that may cause renal failure as well before starting the treatment and before the TLS prophylaxis, and always monitor the urine output of the patient. So for the prevention and management, so again, it is the most important step would be the recognition of the risk and then prevention. Recognition of the risk by, again, identifying if there is a high tumor burden or the question of is it a bulky disease. And then upon more or less recognizing that, the appropriate prevention prior to the initiation of chemotherapy. So standard preventive approach, number one, aggressive hydration. So second would be the administration of allopurinol, which would lower the uric acid level. So urinary alkalization with your sodium bicarbonate is no longer recommended. It increases uric acid solubility, but a high pH decreases the solubility of xanthine, hypoxanthine, and calcium phosphate, potentially increasing the likelihood of intratubular crystallization. So one of the updates would be your febuxostat. So febuxostat is a potent non-purine selective xanthine oxidase inhibitor indicated for the treatment of hyperuricemia. It has less hypersensitivity reactions than allopurinol. Febuxostat does not require dose adjustment in patients with mild to moderate renal impairment. So, febuxostat achieves significantly superior serum uric acid control in comparison with allopurinol in patients with hematologic malignancies at intermediate to high risk to high TLS risk. So other agents would be your resvuricase or your recombinant urate oxidase. This is used when uric acid cannot be lowered by your standard allopurinol. But the problem with this one is that it can cause a very rapid and severe hypersensitivity reaction. So it is not commonly used. Okay, so this is the algorithm for the patient management of tumor lysis syndrome. So before starting or initiating your chemotherapy, again, monitor serum chemistry, the electrolytes that are needed to be monitored, as well as your renal function test, like your creatinine and BUN as well, LDH, blood uric acid, everything that we have mentioned from the previous slide. And then while waiting for the results, maintain your patient with adequate hydration. So usually normal or 1/2 normal saline at 3,000 ml per meter squared per day. Start also the patient on allopurinol or febuxostat. After 24 to 48 hours of hydration, assess the following parameters. Again, your uric acid and creatinine. On the right side, if the serum creatinine and uric acid is within normal, then you can start giving the chemotherapy and monitor the serum chemistry every 6 to 12 hours. But any changes or any problems during or after the procedure, if the following will have abnormalities or will show an elevated result like your potassium, uric acid, crea, phosphate, or increasing symptomatic hypocalcemia, then you should immediately initiate hemodialysis. On the left side, for example, after hydration, administration of allopurinol or febuxostat, your uric acid and creatinine is still elevated. So first, investigate carefully. Are there any other problems not related to the cancer that may cause renal failure? Make sure there is none. If you find anything, make sure that would be addressed as well. So then administer your recombinant urate oxidase. But if still with no improvement or no response, you have two options. You either delay the chemotherapy or start dialysis. And then another option, if the patient persistently again showed elevated values of the following, then hemodialysis is indicated. Okay, so that's it for our oncologic emergencies. Thank you.